going to talk about a topic that's very difficult because there's not a lot of excellent data for us to follow. So I'm going to present this as an overview. I'm going to add in a few things that I think aren't common knowledge, and I'm happy to answer any questions about it. The incidence of nausea in pregnancy has been recorded at 50 to 80%, and vomiting is 15 to 81%. So the typical morning sickness is very, very common in pregnancy. Next slide. So the definition of what is too much nausea and vomiting, or is this severe nausea and vomiting? We basically, as physicians, don't ever score this, but there is actually a puke score. It's PUQE, and it's basically 3 questions that you can score, and it can tell you if a patient has mild nausea and vomiting, moderate to severe, or severe based on the score. Now, let me just say that I don't think this really helps in the management of patients. The only place that I think this is helpful is if me and Eric's working together and I see a patient, she's got severe nausea and vomiting, I try a couple of drugs, and then he sees her 2 weeks later. We can compare our scores to see if anything I did, any intervention I did helped. Next slide. Now, hyperemesis gravidarum is a more serious form of nausea and vomiting in pregnancy. It complicates a 0.3 to 3% of pregnancy. And basically, it's persistent vomiting and evidence of starvation, like large keturia. That's generally what's agreed upon, but there's actually no hard, fast definition of hyperemesis gravidarum. You can get weight loss. Some people include weight loss of 5 to 10%. You can have electrolyte, liver, and thyroid abnormalities. And to my surprise, it's the second most common cause of hospitalization in pregnancy in our country. It's second only to preterm labor. Next slide. So the risk factors for hyperemesis and severe nausea and vomiting are multiple gestations, a complete molar pregnancy or a molar pregnancy, motion sickness, migraines, family history, or if you had hyperemesis in a prior pregnancy. Next slide. So the maternal outcomes, usually with our resources today, there is rarely a maternal death. It's extremely rare. I think we all know Charlotte Bronte, the author of Jane Eyre, is supposedly died of hyperemesis gravidarum. Now, the following, like, we have had cases of Wernicke encephalopathy. I have never seen a splenic avulsion, esophageal rupture. I've seen a lot of Mallory-Weiss tears. I haven't seen pneumothoraxes, but acute tubular necrosis in people with severe nausea and vomiting isn't that uncommon. But in general, maternal outcomes are okay. It's just miserable for the woman. So there are non-pharmacological treatments out there. One, there is actually ginger, and ginger is actually one of the non-pharmacological treatments that have been shown to be helpful in nausea and vomiting of pregnancy. The same company that makes Dramamine actually makes ginger chewies now, and I actually take them, and they're quite tasty. And so I don't know if it helps my nausea and vomiting, but I just like it. I like it. But anyhow, other non-pharmacological treatments is stop prenatal vitamins and just give the patient folate. If a patient's taken prenatal vitamins prior to pregnancy at least 1 month, they're actually have less nausea with prenatal vitamins than if they started during pregnancy. And there's some good data to show that. We obviously tell patients to eat small, frequent meals, use bland food. And one of the non-pharmacological treatments that we don't think about very often is C-band. And you place C-bands at P6, or I'm not even going to try to pronounce that point. But on the next slide, I will show you where the P6 point is. Basically, it's 2 to 3 finger breadths above the wrist, and you can actually feel there's a trough between two tendons. And it's right where that trough starts is where your P6 point is. Next slide. So patients can order C-bands, wristbands off of the internet. They're around $20. You can also get them in a pharmacy. And the little white dots on the C-bands is actually the pressure points that you should put at the P6 point. And so I will tell you, we have residents that wear these that swear by them because they don't want to take medication over the medication, because some of it makes you drowsy and stuff. But we often forget that C-bands is an option. Now, the data is actually kind of weak. You've got a few studies to say that they're helpful, and you've got other studies to say it's not helpful. So, with nausea and vomiting, it's important to start early. Try to start interventions prior to them getting to moderate to severe nausea and vomiting. And the first line of therapy is actually vitamin B6, 10 to 25 milligrams every 6 to 8 hours, and doxalamine, okay, 12.5 milligrams. With the vitamin B6. Now, ACOG, actually, there is a commercial product that's been FDA approved since 2013. It's Diclegis, and I will just tell you, some insurance companies will cover it, and some insurance companies won't cover it. And so we tend to start with the vitamin B6 and the doxalamine, 12.5 milligrams. And I'm sorry, that's Q12 hours. Now, Diclegis is probably the best studied medication in pregnancy. There was a drug called Bendectine that basically had the same formulation that was taken off of the market in the mid 60s because people thought it could be associated with birth defects. And the reason why this was the case, it was introduced into our population on the heels of thalidomide, and there was questions about this. I basically tell patients it is the best studied drug in pregnancy, and I don't think that there's any anomalies associated with it. Next slide. So we often skip over Dramamine and Benadryl for patients, but that is an option. And we go to Compazine and Phenergan. But these tend to be some of your first choices. The issue with almost, all of them is they cause drowsiness. Next slide. So there are other things that we can use that tend to be a little bit more expensive. And those are Reglan. I can tell you, I use Reglan frequently as my first drug of choice in type 1 diabetics who may have some gastroparesis, and it can help stimulate the movement of the gut. The second one is Zofran. You know, there's a sublingual dissolving form of it, and it makes it easy to use in patients with nausea and vomiting. Well, the one we don't think about very commonly is Tygan. The other one we don't think about is methylprednisolone. This can be given orally or by IV. And there are some randomized trials to say that it is effective. And you can give 16 milligrams every 8 hours times 3 days, and then you taper that over the course of 2 weeks. And you can just go down like from 16 to 12 for 3 days, 8 to and then 8, and then 4, and then off. So, or if it's helping the patient and you get down to 4 and they start feeling the nausea and vomiting come back, you can go back up to 8 and continue it over several weeks, but it's not recommended that we continue this for greater than 6 weeks. The issue with steroids is there is a question of cleft lip and palate associated with steroids. And if this is the case, it is a very low incidence. It's certainly not like some of the other anti-seizure medicines that we see with neural tube defects and that type of stuff. Now, the drug that we don't think about very often because it's been hammered home, don't give narcotics and benzos and that type of stuff in pregnancy. But in the day,
Donna, did you mute yourself? Donna, I can't hear you. Dr. Campbell, can you hear Donna? If so, can you unmute?
No, I can't hear her either.
Okay. Let me call her real quick. Sorry, everyone, 1 second. Okay, Donna's logging back in.
Can you hear me now?
Yes.
Okay. So we forget about Ativan, but really refractory patients, I do occasionally use a little bit of Ativan in. But I tell them that at 12 weeks, we are not going to use it anymore. So Zofran, there are two things that we need to be aware about with Zofran. Zofran, if you mix it with other medication, can prolong the QT interval. And I will tell you that it is so common that most of our patients aren't on medications. They're on prenatal vitamins, but that's about it. But if a patient's on psych drugs or things that I'm not very familiar with, I go and look up Zofran and the interactions with that medicine, because Zofran can cause prolonged QT intervals. And with that, it could be sudden death. And so I am just a very cautious doctor, and I do that. I just want you to understand that it's out there, and the information's out there that we should do this. So heaven forbid if something happens to a mom with her on Zofran and a medicine that's contraindicated with that. Now, more recently, there's been data saying that Zofran can be associated with fetal anomalies. This literature is very, very, it contradicts itself. And if there is an anomaly associated with Zofran, again, it is extraordinarily low risk. And I talk with patients and tell them that that we don't really know if it causes anomalies or not. But less than 12 weeks, I do feel like we should at least mention that. And after 12 weeks, I feel like, after 10 weeks, I don't feel like we have to talk about it. Next slide. Now, I will readily admit this, we actually use Reglan and Zofran pumps once in a blue moon. It's for people that we basically can't get out of the hospital. But there is no data that shows that these work. So just be aware of that. And the incidence of complications from them has been quoted as high as 30%. So then the other question is enteral versus parental nutrition on women who are losing weight. You can't keep them out of the hospital. Enteral nutrition is the method of choice. Now, half the women will not tolerate the nasogastric tube that we have to put in order to give them enteral feeding, whereas half the women do tolerate it. If they tolerate it, they do very beautiful. Parental nutrition, we used to just offer that willy-nilly. Especially in the 80s and 90s. But I can tell you the complications from parental nutrition is high, and there is a high incidence of infection and sepsis due to a PICC line infection. And these are very subtle, okay? people come in and they look great, and they just have a low grade temperature of 100, not even what we consider a temperature. And in 12 hours, they will be in the ICU on pressures. So we haven't used parental nutrition now for years, but in the event that there's anybody out there that uses it, I will just say use caution and have a very high index of suspicion for complications. Now, I would like to also talk about IV hydration, because there are people that will just order a liter of fluid to be given on a daily basis to patients. And I actually think that this is where we run into trouble with water-soluble vitamin deficiencies like thiamine and folate and other water-soluble vitamins. And I just think that we should be very careful just using normal saline and not using glucose with also what we call the banana bag with other vitamins and nutrition in it. And so I have seen patients with Wernicke's based on just that alone, getting a normal saline over and over again. And I just think that we should be very cautious with giving patients normal saline. And the last thing I'm going to talk about are the labs that we do. Obviously, we need to measure electrolytes, but it's not uncommon for people to get CMPs and thyroid labs and then call us and talk with us about them. Liver enzymes can be elevated just from nausea and vomiting, and it's if they're less than 300, most of the time I say that this is associated with nausea and vomiting. Total bilirubin 4 or less it can be associated with nausea and vomiting. Amylase and lipase can be 4 to 5 times higher than normal. And so it doesn't mean they have pancreatitis as the cause of their nausea and vomiting. The other thing is that thyroid, I didn't talk about the endocrine aspects of nausea and vomiting in pregnancy, but women who have nausea and vomiting in pregnancy, often their labs actually look like that they have hyperthyroidism. Their TSH will be suppressed, and their free T4, if your upper limits of normal is like 1.5, it'll be like 1.6 or 1.7. And I will see these patients started on thyroid medication to treat their nausea and vomiting or to treat their hyperthyroidism. But I just want to caution you that unless the free T4 is really elevated, I would withhold treatment until after the first trimester. Now, I left about 15 minutes for discussion. And so anybody with questions, please actually let me know. And I would appreciate Eric and Barry's input if they have any more words of wisdom.
Thank you, Dr. Johnson. Just as a reminder, our upcoming session will be on June 15th, preterm labor prediction and prevention. And